Okay, so this is the second lecture in the mammo section. This is going to be our discussion of breast cancer. Just like other modules, 3 basic question types. Okay, so first case. Here we go. We've got a single view of the right breast. Let's take a closer look here. What we're seeing is a whole bunch of different calcifications. So let's talk briefly about this. Different kinds of zooming. So like if you're reading a chest x-ray and you want to get a closer look at the finding, you just put the little magnifying glass thing on it and zoom up, right? That's like a digital zoom. That is different than a mag view. So when people in mammography say, we got mags on it, that doesn't mean they just zoomed in on it. That's a digital zoom, and it's different. The spatial resolution is different, and because of that, this is a testable point. So if you see calcifications on a screening exam, you can't characterize them accurately without getting mag views. So you can't describe the type. You maybe can say if they're in a group or cluster or scattered and that kind of stuff, but you can't characterize the morphology accurately. So most people won't even try until they get the mag views. So that requires coming back and getting a second actual set of x-rays done. So calcifications are described in morphology and then they're described in distribution. Or morphology, there's a whole bunch of different kinds. Some are benign, some are considered intermediate, and some are considered suspicious. I'm going to talk about the benign ones in the next lecture, which will be a benign pathology talk. In this talk, I'm going to talk about the intermediate and suspicious ones. So the general idea on calcifications is that they, at least the ones that are going to cause problems, the intermediate and the suspicious ones, they're going to occur either within the duct or they're going to occur in the lobule. So let's talk about the ductal ones first. So this is sort of the general idea. Of course, you're not going to see the outline of the duct on the x-ray. You're going to see something like this. So this is your calcification that's confined to the duct. The dash dot dash appearance is supposedly classic, like something like this, kind of that kind of thing, like a Morse code kind of deal. That is highly concerning for a ductal carcinoma in situ. Compare that to this, where again you're not going to see the outline, and you've got more of this round or punctate look. Sometimes it's more amorphous, and these are calcifications that are more typically due to debris sort of within the lobules. So these tend to be more benign things like fibrocystic change, although they can represent a low-grade DCIS. These are very nonspecific. So here's the general tips that I'll use for remembering or using your vocabulary words for describing things. If it looks like powdered sugar, or you can't actually count each individual calcification, like if I said, tell me how many of those you are, you can't just say a bunch. If you could actually number them out, or you can't number them out, then you want to say that they're amorphous. Something sort of like this. The next trick is, what if you can count them, but they look dull? In other words, if you pick them up, they wouldn't prick you. That is a coarse heterogeneous calcification, something like this. So you could clearly number them 1, 2, 3, 4, and if you pick that up, that wouldn't hurt you, or that wouldn't hurt you. Now the last one is, you can still count them, but they look sharp. That is your fine pleomorphic calcification. So if you pick them up, it might prick you. So there's a differential that is for each group of calcifications, and this is something you just have to memorize. Amorphous calcifications are most likely to be that fibrocystic change, and that's that debris within the lobules that I was showing. It's just sort of like junk that's stuck in there. You can be a low-grade DCIS also. And the problem with amorphous calcifications is that because low-grade DCIS, which is a cancer, quotation mark, it's a cancer, that it grows so slow that you can't use old films to say that it's, oh, that's benign, that's been there on old films. Yeah, of course it has. It grows really, really slow. So a good trick would be to try to get you to ignore the finding or call it benign or not recommend a biopsy because it was present on prior films. For amorphous calcifications, you can't use that unless it's been previously biopsied. You can't ignore it on prior films. Now, coarse heterogeneous calcification, you will notice that both coarse heterogeneous calcs and fine pleomorphic calcs both have DCIS on their differential. The difference is fine pleomorphic, the sharp ones, that tends to be a higher grade DCIS, and the coarse heterogeneous ones tends to be more of an intermediate or low grade DCIS. So the sharp ones are worse, and the remainder of this differential is the same. So now let's talk about distribution. So there's a whole bunch of different patterns that the calcifications can occur in, some of which are benign and some of which are worrisome. So this is sort of the progression going from not bad to bad. And you can imagine if they're sort of just scattered everywhere, that's more like a fibrocystic change. Regional is also more like a fibrocystic change. But the more that they become like within a pattern of the ductal system, like you can imagine that a linear or segmental could be like all within the same ductal system, then that becomes progressively more worrisome. So the most suspicious, like if the multiple choice question was A, B, C, D, which of the following is the most concerning, that would be regional. If you had to pick between linear and segmental, I would pick linear as being worse, but they're both typically considered bad. I don't think that they would be listed as distractors for each other. If a question like that was going to be asked, I would think that they would give you the ones that are traditionally considered less suspicious versus something that's traditionally considered very worrisome, which would be these two. So fine linear branching is the worst pattern of calcification that you can have, and this basically narrows the differential to DCIS. So if you're seeing that dot dash dot appearance and it's branching and it's like, man, that really looks like that's outlining the duct, especially if they're fine pleomorphic, it's pretty much you're expecting that to be DCIS when you recommend, and you have to recommend biopsy. Some people would even buy RATS 5 that because they're so sure that that's what that's going to be. So DCIS is the earliest form of breast cancer, and it's a cancer that's confined to the duct, as the name suggests. Generally speaking, pathologists will group these into comedo or non-comedo types, comedo being the more aggressive. Some trivia that's useful to know. About 8% of the time, you're going to have a mass present and no calcification, so that's like the atypical thing. Usually DCIS is calcs, fine linear branching, fine pleomorphic calcs. About 10% of the time, there's going to be an invasive component on the biopsy, and if they do a surgical excision, that upgrades even more. DCIS can be shown on multiple choice in 3 classic patterns. The first one is this fine linear branching, fine pleomorphic calcification that we talked about. The second one is a non-mass-like enhancement on MRI, which we'll talk about in the MR lecture, sort of that thing. And the last one is multiple, as in more than one, filling defects on a galactogram. Sorry if you've recently eaten to show you a picture like this. Could be worse. They could actually be your breast. So, you may remember from med school or from residency, if you've happened to see a case of this, that this scaly looking eczema kind of thing on the nipple is Paget's disease of the breast. And the reason I bring this up is that it's associated with a high-grade DCIS, and you have to biopsy the skin to prove that. And the trick question or piece of trivia is that because it's involving the skin, they want you to say that it's a T4 disease. Paget's is not T4 disease. This is an exception. And anytime there's an exception, that makes things testable. So what do you do with Paget's? You can try to ultrasound it, and if you've ever tried to ultrasound right under the nipple, it's technically very challenging, but like I mentioned before, to get the diagnosis, you need to do a biopsy of the skin involving the nipple. Anything that doesn't resolve with a topical therapy. Okay, so next case, we've got a mass, and there's a few calcifications in it. The margin looks spiculated. It's a high-density mass, round. So just sort of reviewing our algorithm here, we talked about this last time. People who come in for just regular screening are considered screeners. These are people who don't have any symptoms. Let's pretend that this is a patient who came in for a screener. So we're going to read that as abnormal, right? So that's going to be a BR0, and then we're going to call it back for diagnostic. Now, if she showed up with a palpable finding or nipple discharge, that's the other way to get into the diagnostic pool. Now, that's probably not going to end up turning out to be normal, just based on that it's going to end up going to the room of tears. So when you get an abnormal screener, how do you decide what to do next? So we're going to get spot compression views of that. When do you ultrasound? When do you do mag views? When do you do other stuff? So this is a general idea, is that if you've got a mass or palpable, those people are always going to get an ultrasound. Nobody with a palpable finding makes it out of the diagnostic department without an ultrasound. Calcifications, those are the ones that are going to get mag views. That's different than a spot compression. So mag views for calcs, and that's to characterize them. And then nipple discharge, depending on its characteristics, will end up getting galactography, unfortunately. So this person came back and they got an ultrasound, and this is a very classic appearance to the for a cancer on ultrasound. Shadowing mass with indistinct borders, anti-parallel, all the bad words. This is a BI-RADS 5. Now, I mentioned this before in the first talk. Before the patient leaves, if you see something like that, you have to scan the remainder of the radian and scan the axilla. And what you're looking for in the axilla is an abnormal lymph node. So, how do you know if a lymph node is abnormal? You're going to want to measure the cortical thickness of the lymph node. This part, from here to here. And around 2.3 millimeters is considered abnormal. On the low end, other places you'll read will tell you 3 millimeters. I expect that if you were shown a lymph node, that it wouldn't be close. It would be 5 millimeters. And you're not measuring it this way. That's wrong. You're not even measuring it short axis like you would sort of in other, like if you were doing CT stuff. You're measuring the cortical thickness, and you're measuring the thickest part. So unlike DCIS, where the cancer is confined to the duct, we're dealing with a cancer that has broken through the duct. And on imaging, this usually looks like a high-density mass with indistinct or spiculated margins. It can have associated pleomorphic calcifications. And on ultrasound, we're going to have this anti-parallel shadowing mass with an echogenic halo. That's like the classic look. So we've talked about DCIS. This would be more of a case of IDC. And I want to point out that the vast majority of the cancers are ductal. A minority are lobular cancers. So most cancers are NOS cancers. These other 4 types that I mentioned actually have a better prognosis because they are better differentiated. So let's hit some trivia that's testable with regard to the different subtypes of breast cancer. The NOS type is the most common, and it has the worst prognosis. Tubular, which is a saying that surfers had in the 1980s, actually has a good prognosis. They tend to be spiculated, which is counterintuitive. You'd think spiculated is bad, right? But in this case, this particular spiculated cancer has a good prognosis. The other thing to remember is that it's associated with this entity called a radial scar, which I'll talk about a little bit more later. Mucinous cancers are uncommon. Medullary is often seen in a younger patient. It has a BRCA association, which makes sense since it's seen in a younger patient. And they tend to have bulky axillary lymph nodes, even if they don't have adenopathy or metastatic adenopathy. Papillary is the opposite of medullary, and then it's rare to actually have that. Rare to have axillary lymph nodes. Instead of being seen in a younger patient, papillary tends to be seen in the elderly. It's actually the second most common, NOS being the most common, so papillary is the second most popular. And probably the most likely way it's shown is with a complex cystic and solid mass. You'd have to show that on ultrasound. So how often is breast cancer bilateral? Around 2 or 3%. If you're using a mammogram, you can detect bilateral cancer. And then if you use MRI, it's about double that. The things that make you more likely to get bilateral disease, genetic stuff. Lobular cancers are more likely to be bilateral. And multicentric disease. And if you remember from the first lecture, multifocal is when they are clustered in the same quadrant and they're close together within 5 centimeters. Relative and multicentric, like a multicentric trial, or from multiple cities, are in different quadrants. So different quadrant disease is more likely to be, some people will say that's because there are different primaries. And then if you've got different primaries, then you've got different disease in both breasts, more likely also. So this lends itself really well to multiple choice as far as which of the following patients would be most likely to have bilateral disease, multicentric, lobular, BRCA carriers? Okay. All right, so this is an Ant Mini. This is one of the mammography Ant Minis, where this is actually the same patient. She's not had any surgery. And what we have is a shrunken breast. Sometimes this is shown with multiple years of mammography, where it's got a normal sized breast and it appears to be shrunken when it's compared to the prior. So this is a classic way of showing ILC, lobular carcinoma, as opposed to ductal. This is the one that's like the 10%er. And what you're actually seeing here is, if you would examine this patient, or they would show you a picture of the patient's breasts, they would look symmetric. They would look like they were the same size. But the breast just doesn't compress because it's infiltrated. So on the mammogram, it appears to be shrunken. Another pearl to mention also is that sometimes you only see this on one view. You don't see it on both views, and it has to do, again, with how it compresses. Alright, so here are the three ways that you are classically shown ILC. The first is the shrinking breast. The second is something called a dark star, and which I'll mention in a second. And the third is on ultrasound, where you have shadowing, but you can't actually make out a distinct mass, and that's like a buzzword. I feel like if there's a lot of shadowing, it always sort of looks like they're a mass, but if it's described to you as shadowing without a mass, they are hinting that this is an ILC case. So a dark star is architectural distortion without a central mass. So in other words, it's dark in the middle. And that has a differential that includes lobular carcinoma and radial scar. Now, surgical scar is also listed here, but that tends to be more of what they call a white star, which has it will be white in the middle also. So here's some trivia about ILC. It tends to present later in an older population. It's not that ductal calcification, fine pleomorphic stuff that we talked about with ductal cancers. Mets to the axilla are actually less common, and it's more often multifocal and bilateral, which I've mentioned a couple of times now. All right, here's our next case, and do a zoom up here. So do you get the feeling that things are being pulled into a certain area? It's like somebody has grabbed it and pinched it from the inside, like pulling stuff together. This is what they call architectural distortion, which I've mentioned a couple of times. So it's where you could have lines like this that sort of intersect each other. People will call that just summation. That's different than all the lines sort of heading together. Like they're all, if you think about a map with airports, going into different cities, all the lines going to one city, that's architectural distortion. So there's a differential, IDC, ILC, radial scar, and surgical scar. This is a classic differential for architectural distortion. Basically, if they haven't had surgery, it's something bad. There's a next case here. Slightly different technique used the point is to show this skin thickening. So notice that the skin is usually super thin, like this right here. That's normal. That's what the skin's supposed to look like. Look how thick this skin is here. And I'll tell you that that's a really bad sign, because that's one of these like secondary signs. And skin thickening basically occurs if you've got this entity, inflammatory breast cancer, if you've got mastitis, or you could see skin thickening if somebody had congestive heart failure and they had just like an edematous breast. You would expect that to be bilateral. Unilateral, it's just going to be inflammatory breast cancer or mastitis. So typically the algorithm is somebody comes in with a red swollen breast. You may or may not be able to find a mass. They'll put them on antibiotics. It better completely resolve, and you have to like follow them up, short interval follow-ups until it resolves. The trick is that inflammatory breast cancer can sometimes get a little bit better with antibiotics, which doesn't make a lot of sense, but just can. But it won't completely go away. And if it doesn't go away, you have to end up doing a skin biopsy to prove that to prove that it's not this. Inflammatory breast cancer has a horrific, terrible prognosis. They tend to do chemotherapy first just to try to get it under control. And the mastectomy is typically described as like it's just an attempt to slow down the cancer, that it's not even a curative measure. It's bad. Inflammatory breast cancer is bad. All right, zoom in here. We've got some calcifications. So if this was a screener, we just did a digital zoom there, we would BR0 that and bring it back, and we would recommend mag views, right? Because digital zoom is not the same as magnification. Okay, so this is a real mag view. Remember, the digital zoom does not count. You have to bring them back to get actual magnification views so you can characterize these things. And these definitely look suspicious to me. I would call these fine pleomorphic. So this is going to get either a BI-RADS 4 or BI-RADS 5. And I'll point out some differences on how you handle these things. So you're going to basically have three options. Either benign, high risk, or malignant. If you BI-RADS 4 it and it's benign, they get to go home. Now typically people will follow their patients up close. They wouldn't wait an entire year to bring them back. They'll bring them back in 6 months. Some people might even bring them back in 3 months. I don't think there's a hard rule on that, but just know that most people will bring them up back a little bit shorter, even after a benign result. High-risk lesion, which is something we're going to talk about here in a minute, will go to surgery to get an excisional. They'll get that part of their breast excised. And then cancer is obviously going to get to meet the surgeon. Now, BI-RADS 5 is going to be different. You're still going to have three different options, but if you BI-RADS 5 something, you're basically saying, I'm telling you this is malignant. So you would not accept a benign result. You would describe that as discordant or not concordant, because with BI-RADS 4, you're saying it's possible it's benign, I'm just not sure. With BI-RADS 5, you're saying it's cancer. So even with a benign result, with a BI-RADS 5, you have to send them for a surgical biopsy. And then the other two are the same. So what are these high-risk lesions? These are things that are associated with cancer. They're not cancer, but they're associated with cancer, and they're going to get a surgical excision when they turn up on your biopsy. And they're just things you have to memorize. There's 5 of them: ADH, ALH, LCIS, radial scar, and papilloma. And I'm going to mention just a couple of trivial points about radial scar and papilloma. Radial scar, as I mentioned before, is in this dark star differential, and it's associated with tubular cancer. That's the two things you need to know about it. Papillomas are the most common intraductal mass. They're a very common cause of bloody discharge. and they tend to be a solitary filling defect on galactography. They also tend to be located right underneath the nipple. About 90% of them are found 1 centimeter from the nipple. They can sometimes be shown on mammography, and if you remember that they are in the differential for coarse, heterogeneous, and fine pleomorphic calcifications. So, galactography on 2 different patients here. Do a zoom in. One with multiple filling defects and one with a solitary filling defect. So the multiple filling defects, I showed this before. This is DCIS. This is one of the classic ways to show DCIS. And then the solitary one that's close to the nipple is a classic way to show papilloma. So what makes suspicious nipple discharge? Because you can have nipple discharge from lots of different reasons, but when is it suspicious? If it's spontaneous, if it's bloody, and if it's from a single duct. So if it meets these 3 things, most people are going to unfortunately have to perform a galactogram. Now the contraindications for any procedure are always testable. You would not do a galactogram if the patient was infected, because you're going to be like squirting stuff in there. You're not going to perform a galactogram if they have mastitis. If they're unable to express a discharge at the time of the exam, because you have to know which duct you're going to cannulate. Or if they've had surgery to the nipple before, and that's going to make it basically impossible to cannulate it or to cannulate the single duct. So you perform it, you put just a little bit of contrast in there, you take mammograms, and if you see filling defects, then typically perform a wire localization at that time, and then send them to surgery to have that excised. So the last thing I want to talk about is the different subtypes of positive predictive value. Mammography has all kinds of statistics that it keeps on stuff. These are the 3 that are related to this cancer workup. So PPV1 is anything you call back from screeners, basically anything that you didn't send back into the screening pile. And that should be around 4%. PPV2 is anything in the diagnostic setting that you recommended a biopsy on. In other words, BI-RADS 4 and BI-RADS 5. And this should be around 25%. And then PPV3 is anything that you did a biopsy on and you got a malignant result. So how many times were you correct in actually recommending that biopsy? And that should be around 30%. Okay, that's it for this talk, and the next lecture will be on benign findings in the breast.